Please welcome our first panel, The Future of Academic Medicine, Dr. Carlos Del Rio, Dr. Gene Sumner, Dr. David Hess, and Dr. Valerie Montgomery Rice.
Good morning, good morning, good morning. I saw all of those people leaving to go listen to something about the disruptors. I think they were confused about what is really a disruption, okay? Academic medicine. The one thing that we get to be so proud of is that everyone in this audience has been touched by something related to academic medicine. And we know that while there are a lot of things that are trying to disrupt how we educate and train, who we educate and train, we know that we are committed to this mission of educating and training the next generation of healthcare professionals, of biomedical scientists, of public health advocates, of community engaged, community thoughtful leaders that are going to help us achieve optimal health for all. So while some are thinking about the SCOTUS decision and the repercussions of that, or how technology is going to impact academic medicine, we on this stage are embracing all of those disruptions because we know that you all, with your curiosity and your youthfulness and your zest for learning, are going to require that we embrace all of that because the world needs what we all do best. And that is what academic medicine is really about, bringing forth diversity of thought and experiences to ensure that we can deliver on the promise of science to the communities that we serve. So I am happy to be here today to talk about the future of academic medicine. And it really is about driving advancements in research, medical education, and patient care. There's a lot going on in medicine. We're going to hear a little bit about medical technology. We're going to hear a little bit about how we keep up with this unprecedented rate of new diseases that are emerging. We're going to hear about what we need to do as leaders in this space to equip all of us to be a part of the solution. So I thank my colleagues for joining me. And I'm going to start with the question to Dr. Carlos Del Rio. You all saw him on television. He became sort of a nightly part of CNN and MSNBC and anybody else whose calls he would take to sort of guide us through the pandemic. And you heard Deb, Leadership Atlanta Class 2013, let me just say that, Deb Howery. We always have to give it out. You heard her talk about the CDC's response, but I would like for Carlos to sort of set the stage from a health system perspective, because that really required us to sort of reset and rethink about academic medicine. Carlos.
Well, thank you, Dr. Montgomery Rice, and thanks, Health Connect South, for the invitation to be here. You know, academic medicine is at an incredible inflection point, and I think while we have always been, realizing that we need to change and we need to adapt, I think COVID was clearly a point in which, we need to think. Many people said, well, at the end of COVID, we're going to go back to normal. I think we can go back. We have to go forward. And I think the disruption that has occurred is causing a lot of, I would say, still unsettling and a lot of trying to understand how to chart the way forward. I think there are challenges in all components. The academic medicine sort of structure typically includes, at the center, includes a health system, whether it's a hospital or a health system, providing care for patients. And we know the challenges that we're having over there, challenges related to personnel, challenges related to supply chain, challenges related to patients that are sicker and that have lost a lot of trust in what we do and what we provide to them. Then you have obviously the educational component, and as many have written, but I think few people as eloquently as Dr. Montgomery Rice, medical education continues, and it's more than ever has become an elitist profession. The people going to medical school are in general well off, and the people that graduate from medical school are in general graduating with tremendous debt that limits their abilities to do the kinds of fields of choose professions that we would like them to choose. We have seen over the last 15, 20 years essentially a flat number of the percentage of African Americans in medical schools, and especially if you look at African American males, we have not seen any change at all despite talking about improving this. And we have seen the same thing with other racial and ethnic minorities, Hispanics, for example, et cetera. So we have to rethink how and that's why you see many places saying we're no longer going to follow the U.S. News and World Report rankings. That's why you see many places say we're no longer going to pay attention to, MCAT scores and other things, because we have to think, how do we change the playing field in significant ways? And finally, there's the area of research, right? I mean, many academic health centers, and I will say, mine included, have really seen research as the pinnacle of what they do and the most important mission what they do. But the reality is research, while it's incredibly important and brings a lot of innovation that then impacts patient care and impacts populations, in many times research has become sort of a separate industry, a separate component, and it's increasingly separated from what the rest of the academic mission is. So you see, and that it's what you would expect to happen, because research is becoming more competitive, and the people that are good at doing research are people that, quite frankly, are not spending time doing teaching or doing patient care and doing other activities. So in a way, you're creating this parallel environment that, of course, wants to be supported and wants to be taken care of. So the big question for academic centers today is, who are we? What's our mission? What are we here to do? Mm-hmm. And the reality is that's what we're here to answer, right? And if we don't realize that at the center of what we do has to be our patients and has to be our community, then we're failing in our response. So the future of academic health centers is really in our hands, but it's really going to depend on our ability to listen, our ability to listen to our community, our ability to adapt, and our ability to get uncomfortable and step outside what we have been doing thus far. Because if we don't do that, if we just think, well, it's business as usual and we'll continue doing what we've been doing, we're going to be fine, the answer is no, we're not going to be fine. Those that don't adapt will not survive.
Thank you, Carlos. And so let's sort of break that down into a couple of verticals. And I want to talk about the healthcare workforce. And when I say healthcare workforce, I'm not talking about just MDs. I'm talking about everybody who touches a patient or the community in an exchange of trying to help them achieve their optimal level of health. So I'm trying to be as inclusive as possible. Now, most of us have a medical school with MD students and PA students and MPH students. And so I want to focus first on that group, and I'm going to ask David and Jean both to comment on this. How do you believe we should address the capacity needs? Because we saw in COVID that we had capacity shortages, particularly in the nursing area, particularly in people who were willing to be at that bedside, taking care of those patients. So how do we address those capacity needs? And I'll give this one statistic. When we looked at Morehouse School of Medicine, I was just looking at this yesterday, in 2021, we saw about a 25% increase in applications. So we went from our usual 6,000 to 7,000 applications to like 9,000. And then in 2022, we went back down to 7,000. I don't know if you saw that. And I do believe that that was a Fauci effect. I don't care what anybody says, that was a positive impact. People saw that they could potentially make a difference in people's lives. So I want to know what you saw, and then how do we address the capacity needs? And I'll start with Eugene.
I think the most important thing we can do is, as educators, is to really take a hard look at how we educate and who we educate and broaden that pool. I know that physicians aren't the only part of that, but we've changed the way we admit. We look seriously at about 40 factors. Mercer is a school that addresses rural health, and particularly rural health in Georgia, but sometimes you forget that most of the world's population lives in a rural area. And I can tell you, those counties do not have care out in rural Georgia. You may think they have somebody. The data from rural areas is abysmally poor. You know, they can't tell who's there, who's practicing. And during COVID, 6 of Georgia's counties ranked in the top 20 in the percentage of deaths at one point. You drill down on those counties, they were almost all communities with a majority African-American population, and they had no primary care. They had no hospital, they had no place to go, and they had uncontrolled chronic disease. They need care. They need physicians in those counties, but they need other people too. They have pharmacists, and pharmacists are terribly underutilized. What can that pharmacist do that helps? We need nurses. According to the American Nurses Association, there's no place in this country that will be short of nurse practitioners, no state, in 2025, but every state is short of bedside nurses and nurses who care for patients. And nursing is an incredible profession that lays a foundation for healthcare. Our practice depends on quality nursing in many ways. The former speaker talked about, you know, messaging and putting people in rural communities. But one of the things that we can do now is improve health literacy. You know, I spent my life in a small town taking care of people who were solid rocks, but they did not know much about health care. And you'd say, you know, we've got to work on your weight. And they'd say, Doc, I didn't eat much. And I said, well, tell me what you had for breakfast. Well, I had 2 ham biscuits and some grits. And I'm not making fun of that. Culturally, that's Southern food. They don't know the difference many times in grits. They think of grits as a vegetable. So understanding, I personally feel going back to maternal health, infant health, prenatal counseling, preparation for pregnancy, educating that mother, because women and parents set the tone for their families. And they want their children to be healthy, and I don't care if they're rich, poor, educated or not. They care about their families. And if they have a trusting relationship with a care provider who gives them good information, they're going to do their dead level best to follow that. And then they set the tone for the entire family. The child does better in school, and the process works its way up instead of working its way down. We educate diabetics with peripheral vascular disease and stroke, and we spend all our hours talking about what we're going to do now, but we should have started that years earlier. Many of you don't remember because you're young, but there was this aggressive stop smoking education in public schools. I'm from a family of physicians. We never smoked. I hated smoking. My children were in public schools, and they got that drilled into them. Don't smoke. And when they were little, we'd be sitting in a restaurant, and you'd miss one of them. They were going to somebody in the restaurant that was smoking to tell them the smoking would kill them. You know, right. And so that mattered. They wouldn't smoke. They won't be around smoking. But there's so many things that we can get into the schools that go home to the family as well. So workforce is important. Physicians, nurses, pharmacists, CNAs, LPNs, but engaging the patient and their families in that as well.
So, Jean, I hear you saying medicine is a team sport.
It's a team sport.
And one of the solutions, we want to talk about solutions, is improving health literacy.
Absolutely.
And beginning early in utero.
Absolutely.
So, because that can transcend across a person's life.
Absolutely.
David, what are the things that you see as a challenge for us meeting the capacity needs in the healthcare workforce?
Yeah, well, I think we need to clone Jean Sumner, because when she left primary care, we probably had to replace her with 10 physicians, right? So, but yeah, and to echo what's been said, I agree with everything that's been said, is Georgia ranks 40th in physicians per capita, and that's in light of a national shortage. And of course, there's an imbalance You know, some counties in North Atlanta are pretty well staffed, but most counties, particularly south of I-16, are very short. We have some of the worst health measures in the country. You know, we're the stroke belt, we're the amputation belt, we're the hypertension belt, we're the dementia belt. And a lot of this is preventable. The other problem is when doctors graduate from medical school, they do residencies and internships called graduate medical education. And whenever you ask a question about Georgia, just say 40 or below, because we rank 40th in the country in residents per capita. So the problem is we're a net exporter of medical students because there's not enough GME slots. And generally, where you do your residency is where you practice. So if we don't have more GME slots, we're really in trouble. And, you know, to do endocrinology fellowships or, you know, advanced fellowships, basically Emory and us. You know, we don't really have a lot of specialized. So we're shortage of primary care, and we have a shortage of specialists. One way to address the shortage of specialists is telemedicine and digital health, and to supply physicians digitally or by telemedicine, because we got to support. And lastly, you know, a lot of physicians are reluctant to go to rural areas because they're physician deserts. They're worried about the schools. They're worried about the infrastructure. So we got to set up practices where they take and keep, because we can produce all the doctors we want and we don't want them to burn out. But again, we also have to create more GME slots in Georgia.
So David, you touched on this, how we deliver care and where we deliver care. What are the new tools that we can use to deliver care? Let's spend a little bit of time on this, because I think this is going to get us to talking about partnerships. And I'll start with you, Carlos. Can you tell us some examples of some more creative ways that you've seen us integrate technology or new modes of delivery of how we are reaching patients, citizens, residents, where they are, and how we are delivering care, and what are some of the benefits of that and some of the risk?
Well, you know, as David mentioned, I think in COVID we all started seeing the advantages of telemedicine, but I would tell you also that the challenges of telemedicine is there's a huge digital divide, and there's a huge, you know, digital inequity. So I would have many patients that I would see at Grady who simply could not do telemedicine. And in fact, many patients were able to do a phone call, but they were not able to do telemedicine. And part of it has to do with, you know, the kind of cell phone plans they had, the kind of how much they paid for it, et cetera. So the digital divide is one that I think it's something that, again, is yet another health inequity in our country. If we think telemedicine is going to solve everything and we don't solve that digital divide, we're going to be in serious problems, because that's not going to help us. The other thing is, you know, we're still in a country that the states regulate care, and the states regulate who you are and who can practice there. So while during the pandemic, I couldn't do telemedicine in somebody who was in Alabama or in other state, that's no longer the case, right? You cannot do that. So somebody who lives in Alabama or who lives in a rural county in Florida cannot do a telemedicine consult with me because I am not practicing in that state. So we also need to look at how our regulations impede our ability to do many of the things we would like to do. There's a lot of things that can happen. We see a lot of health apps that have emerged, and I think increasingly we're going to see companies like Amazon and many others get into the healthcare space. We're going to see, you know, the CVSs of the world. We're going to see pharmacists. We're going to see everybody move into this, because the reality is a lot of the care is going to happen outside of hospitals. A lot of the care is going to happen outside of our traditional clinics, healthcare settings. Is going to happen in pharmacies. It's going to happen in, I mean, I'll give you an example. I went to get my flu shot and my COVID vaccine at a pharmacy, because to get it in my healthcare system will be really hard, right? I mean, I have to, you know, do all sorts of things. Going to CVS, I walked in, I got my vaccines, I was done. So that's a great place to get that delivery of care. And I was offered, you know, hypertension screening, et cetera. So they're moving into that space very well. So when we talk about partnerships, we have to think, how do we partner with those places in the community that are doing this? But the other place where healthcare is increasingly happening is in the home. And we need to understand, how do we do that? And we need to understand is, how do we support healthcare happening in the home? We are all in our hospitals having significant issues with people with length of stay. You know, patients are staying longer in the hospitals, and they're staying for a variety of reasons, but one of the reasons they're staying longer is because there's not enough long-term care facilities and places to discharge people to. So how do we rethink that? How do we think about, okay, what can we do at the home level? What can we do going back to home visits? What can we do back to, the physicians or the healthcare worker or the community worker that goes out there? And I would say that as somebody who has worked for a long time in global health, we really need to think about what are the reverse innovation. What have we learned from the care that we deliver doing, antiretroviral therapy care in Africa, for example, through PEPFAR? And what are the lessons learned there with community health workers and other things that we can apply in our country? And I would tell you, the outcomes of HIV care in most of the PEPFAR countries are way better than in our country.
Better than ours.
So
Yeah.
we need to start thinking about we are not perfect, we are doing things the right way, and we need to look for solutions. And many of the low-level solution, low-level interventions are where we need to go. So a lot of times, yes, it's technology, but a lot of times it's, quite frankly, is utilizing people appropriately and thinking about what do you do going back to the patient, to the family, to the home. But going back to what Jean said, that's when health literacy matters, right? That's when really understanding how you partner with people in the community. How do you get community health workers to be out there? And I will say one last thing, and I said this in global health, and I'll say it here. Community health workers, community-based organizations, they're not volunteers. We have to pay them. There's no way we can continue saying, oh, community health workers will do the work and do it for free. No, they need to be employed and they need to be paid appropriately if we're going to totally partner with them.
Well, I will say that the state of Georgia has stepped up, and they have been implementing in the Department of Public Health many training programs. Morehouse School of Medicine and others have training programs where we are seeing community health workers being used as the right type of paraprofessional to help us in this process. And Jean, let me touch on something as we think about how and where and when we're going to deliver care and asking people to use less technology or more technology. How are we changing how we educate and train our medical students or our residents for this new reality? That first of all, medicine is a team sport. Secondly, you got to utilize or be dependent on others for ensuring that the patient is going to have the most optimal response. So how are we changing or adapting our curriculum?
I think that every medical student should understand that it is, we keep using the phrase team sport, but it takes everybody on your team, and you depend on your team. You depend on the quality of the nursing assistant, the observations of the nurse, the skills of the CRNA or the anesthesiologist. It takes all of us to practice medicine. It is even more evident when you drill it down to a simple community where I lived and practiced, that everybody in that community matters. I used to say there are no turf battles in rural Georgia. If you can do something, do it well, you're welcome, because there's not enough of us. But I think that our training, physicians tend to be the leaders of those teams, and I believe in physician-led care, but we need to understand how to lead that team, and we need to be able to delegate and cut through some of the bureaucracy with the patient as the primary source. The patient is the center of that care. Sometimes it's us. We're worried about our hours, our time, we're tired. It's a human being you're taking care of. And I get that everybody worries about quality of life, and I do too, and I'm not trying to be hard, but we need physicians and people who understand their obligation. You took an oath to care for a human. So we have to care for that human at 4 o'clock or 6:30. We need to be
What
there.
about the 80-hour work week?
Well, I know, and we're regulated, but we come through training programs that are highly regulated, limited hours, and then reality sets in.
Yes.
And I hear from hospital administrators all over the state, we don't see the workers coming out of training programs with the resilience to do this job. It's a hard job. It's a great job. I believe it's the greatest job you can have, to be a physician. It gives you so much opportunity, and I'm grateful for that opportunity, but I'm also grateful for my colleagues. So you've got to train that team, build that team, empower that team, and be available. I do think telehealth plays a role in that, and I do not think it will replace us. And I won't go into my ideas about licensure, because if you aren't...
I think we should have that sometimes,
Well,
talk about that, just have
I'm
that
not-
discussion.
Licensure is important. Think of this. If you have universal licensure, and I'm a doctor sitting in the Philippines, and I'm not such a good doctor, but I get a license in California, but I'm in the Philippines, and I can treat anybody in this country, and nobody can come after me in the Philippines. You know, there's no protection for the patient. And also, some of these for-profit organizations that have organizations that do video calls and prescribe, patients sometimes don't know their own history. They don't know what medicines they're on. They don't know their allergies. And they do harm. And then when the patient gets in trouble, there's nobody there to take care of them. And the people around them may not know that that's where they got their prescription from. So I think there are a lot of issues. I think integrating telehealth into practices. David and I got to know each other as I was a young physician. He was a lot older than me, but no. But he came to Augusta, and we started he started the telehealth stroke program in Sandersville, Georgia, where I'm from. We did a lot of thrombolytics in that little hospital, and I was an internist. It was an ER without coverage. I'd come in at night, somebody had a stroke, call Augusta, they'd say, give it, and you felt like Superwoman. And they could look at the patient through telehealth. I spent years on the phone with the doctors from Emory that I never saw, but they taught me so much, because I was the only doctor in my county. So I'd call them up and say, this is all I've got and what I do next. And they were my friends, and I'd send the patient to Atlanta, and they'd come home and say, that doctor actually knew you. He really doesn't, but he's a nice guy.
Right, exactly.
But we have got to bring care to the patient and think about building a system around the patient instead of around the team, and empower our colleagues to work to the top of their license.
So I think that is really, really critical, for us to have this discussion around licensure, because lots of people believe that physicians are resistant to other healthcare providers being able to practice to the top of their license. And I think most of us feel that we need to have guardrails around all of us to ensure that the patient is going to have the optimal level of care. But we welcome the opportunity for people to be able to practice to the top of their license, because it means that the person is going to get a diverse perspective, an engagement, and hopefully an optimal level of care. So I wanted us to have that sensitive conversation to know, and we think about this a lot as we're educating and training this next generation. We are ensuring that we have curriculums that incorporate our doctors and understand the contributions from the respiratory care therapists, from the nurse practitioner, from the medical assistants, from the people who greet persons at the ER, because sometimes they get information in that engagement that gives us a view into the social determinants that may be impacting a patient's opportunity to adhere to some of the recommendations. All of this leads to me, David, thinking about partnerships. Let's talk about some of the partnerships, whether it's with industry, whether it's in research, whether it's with our pharmacy, whether it's our pharmaceutical companies, that can lead us to thinking about the future of academic medicine.
Yeah, thank you. Maybe I'll start with health system partnerships, because those are so important for all of us here, because we educate our students all over the state. And so we've had, fantastic partnerships with a number of health systems. I could name some. If I leave somebody out, the CEO will be emailing me after this or texting me. But, Phoebe Putney in Albany has been a great partner, for one example. St. Joe's Candler in Savannah, Southeast Georgia Regional in Brunswick, the health systems in Rome, Hamilton Health, and Jeff Myers in Dalton, and recently Wellstar, MCG Health. We were, as a safety net hospital, financially stressed, because we're a safety net hospital. That's the issue with being an academic medical center, and that partnership just closed, and that's a tight partnership, right? That's really a merger, but that was important, I think, really for the good of the state and really the rescue of our academic medical center. But we have to train our students. We can't train them all at our medical schools where we are. We can't just train them in a few cities. We've got to send them out, and that's really the strength of much of what we do. We send them out, and they get to work in communities. And studies show from the AAMC that if you go to medical school and you go to a regional campus and you practice in that community, you're more likely to practice in that community long term. And then while we love to have residents and fellows, sometimes it's good to have medical students, as we say, unopposed by residents and fellows. When I went to, I'm embarrassed to say this, but it's true, when I went to University of Maryland School of Medicine, I delivered one baby because I was 5th in line, and that was not really delivered by me. Now our students go out and they'll be involved in 30 or 40 deliveries in rural areas. So that's really important to be unopposed, but then we're dependent upon volunteer faculty. And some of you probably are volunteer faculty, and I thank you for the bottom of my heart.
Yep.
But you do, at least in Georgia, get a tax credit. The PTIPS program, the Provider Tax Incentive Program, is not just for physicians, but it's for nurse practitioners and PAs. And that's a tax credit. That's real money in your pocket. And they don't just do it for that, but it's at least a way of saying thank you. So,
And David, if I can interrupt you for a moment on that point, that was a collaboration with AHEC and all of the medical schools pushing the legislators to say, we need a process and an incentive to capture the resource out there for all these people that we've educated and trained and put out there in the communities. We now need them to extend that learning to our students. And the legislators work with us, with AHEC and others, to get this passed. So this is one of the things that can lead to success when we collaborate. Excuse me for interrupting.
no, you're absolutely right, Valerie. And that's a model for other states. Other states always want to copy Georgia now. So that was big, but I think health system partnerships are absolutely essential. And then, as we'll end, partner between the medical schools here, because we're really not competitors. We're really collaborators, and we're all in this together.
Right. I think, when I think about the partnerships that we have, first of all, we have one of the best partnerships with the state of Georgia. And it's a private-public partnership where the state of Georgia does partner with us to say, how can we address health and achieving health equity in the state? When we were thinking about opening up our Columbus Regional Campus, the first thing that people said, you're going to be competing with Mercer. And what Jean and I did was get on the phone and say, how can we dispel that myth that we are competing? We are now looking at in Albany. And we decided at Morehouse School of Medicine to open up these regional campuses because it's what the community needs. And yes, Mercer has a presence in Columbus. University of Georgia has Augusta. Okay, what is your name now? Augusta.
MCG still.
I always mess with him. MCG has a presence in Phoebe Putnam, but we were down in Phoebe Putnam the other day, and they have one of the best simulation centers that I have ever seen in the country. At least 20 rooms where you can do simulation, all healthcare providers, educating and training people without them having the patient being the first person that you put that needle in or run that code on. And it was really, really remarkable. And we have instances like that in the state. Let's talk a little bit about research, because I think our CTSA doesn't get enough credit. Carlos, you want to speak a little bit about that and what we've done across all 4 of our campuses?
Yeah, I certainly would do that, but I just want to add to what was talked about partnerships. I do worry about what I see as not necessarily a partnership, but a takeover, and something we should probably discuss, which is the increasing role of private equity in buying practices and getting involved in care. I mean, that is almost like I hate to say it, but almost like a cancer that is spreading and we're not quite seeing it. And I think that is not a partnership, but a takeover that we need to talk about. So research, as I said, research is an important part of the mission of academic centers. NIH several years ago came up with this idea of the CTSAs, which is a big word for clinical and translational research units or research hubs. And the idea is, how do you get different institutions, different organizations to collaborate around research and to look at ways to pull in their strengths into doing two things. Number one, research training, which again, it's a really critically important aspect of what we do is how do you train the next generation of researchers? How do you train research teams, research coordinators, and you name it. But number two, how do you get institutions as separate as, for example, University of Georgia that has an incredible school of pharmacy or has a veterinary school, how do you get them to come to the table and think about working with Morehouse School of Medicine, with Emory, with MCG, with Mercer? How do you bring different places together? And I think what the CTSA really does is really creates that platform that potentially can create those partnerships. And we've seen incredible things happening as a result of that.
Right.
Because it really allows you to see everybody's different strengths and weaknesses, and how do you make the sum of those strengths better than each one of those units independently. And we have to realize that we cannot do it all by ourselves. I mean, there's no point for Emory to have a school of pharmacy. There's plenty of other schools of pharmacies that we need to partner with and we need to work with, and I can go on and on saying that. So how do you bring people to the table? Because part of creating partnerships is actually looking at your strengths and weaknesses and seeing how can you partner with somebody to make sure that those strengths actually benefit all the institutions involved.
And we definitely want to see more partnerships. I would be remiss if I didn't call out the Georgia Research Alliance, which all of us are members of. The Georgia Research Alliance started way back, when we had tobacco dollars, and they pooled dollars together, and they recognized that we had at the academic institution lots of scholars who were doing translational research that could benefit and be an economic driver for the states. And so we saw all of us now have some level of a Georgia Research Scholar that is really promoting education and training of a next generation, but also new discoveries that really make a difference. I also see GeoVax out here in the audience with David Dodd, and GeoVax is looking at COVID-19 and monkeypox vaccines. And so we have industry partners that are wanting to work with us in academia, because they know that if we were going to try to stand up a clinical trial, we would be the ones who could stand up that clinical trial. So I want, as we start to close, I want us to talk a little bit about collaborations and partnerships that are missing among us or within the state that we would like to see and have this audience to help us think about, that we can sort of serve as a catalyst to. And I'll start with you, David. What type of collaborations or partnerships do you feel that may be missing in the state that would really advance the future of academic medicine?
Yeah, it's a good question. I think amongst ourselves, there's a great opportunity here. We're so busy, we tend to be siloed, right? We're so busy with our own medical schools, getting LCME, certification and accreditation and things that it's just natural to be siloed. So this is a great opportunity. Thank Russ LaPerriere for getting us all together. I think that was the secret agenda, to get us to work together. But then to really work, our dream is always kind of a statewide academic research clinical health system, and there's no reason that all the medical schools can't be involved in that. Because we can be at multiple health systems. We just have to be careful with our affiliation agreements, but we're much stronger together. I think the CTSA is a great example of how that's already happening, and I think we can enhance that and continue to meet amongst ourselves. Just like you've done in Columbus. You can have two medical schools there. In Savannah, we have two medical schools. There's plenty of opportunity. The need is so great that none of us can cover it, even if we were twice our size.
And I think about what happens with us at the VA. When you are practicing in the VA, you're a VA doctor first. Now, you may have academic affiliations, but everybody understands you are there to care for those veterans who have sacrificed so much for us. And we really need to make sure that as we think about being Emory and Morehouse and Grady, or when we go down to Phoebe Putnam, that first of all, our primary focus is to care for the patients there, regardless of what that patchy is on our sleeve. That only gives us some level of identification. But our first level of identification is taking care of those patients. So, Jean, what type of partnerships and collaboration do you think are missing, and that maybe this can serve as a catalyst?
I want to echo what David said. I think that this alliance is powerful, and we all like each other, and we all get along, and we have fun together. But we have a huge job. I think no one on this panel thinks of this as competition. We each have our areas of expertise. We work together. If there's a problem, we call each other up. That's great for Georgia. It's great for the nation, but expanding on that and really committing to covering Georgia. We've got to engage, and I know I sound like I'm one word. We've got to engage rural populations. They never get in a clinical trial. And if they get in a clinical trial, they have to drive 80 miles and then follow up, and it just does not work. And they've been fooled and mistreated through the years, and you have to build trust. And so we spend a lot of time building trust. So the collaboration with those communities and engaging every county in the state has a public health department that I think has great opportunity to house response, to have follow-up and other things to do that we can guide. And so those collaborations, so that would be my thought. We have entered into a collaboration with Children's Healthcare for rural health, and they're in Atlanta, and this is not an effort to bring people to Atlanta, children who don't need to come to Atlanta, but it is an effort to bring them to Augusta, to the Children's Hospital, rather than flying them to Atlanta, and to communicate, because, to Augusta or to Columbus or to Macon or to the regional children's hospital or to the local hospital or to the next county, because there's 63 counties in the state with no pediatrician. And so if there's a pediatrician in the next county, and we're building that collaboration to try to keep that at home, and then there's opportunity there to look at best practices to spread them through other areas.
And Jean, one of the ways that we're going to be able to address the provider shortages in the state of Georgia is that we have to recruit students from the state of Georgia. And we have to ensure that the K through 12 educational experience that they have is strong enough and encouraging enough for them to believe that they can be a provider. We have, I believe at the last count, somewhere around 20+ counties in the state of Georgia that have never graduated a student from high school that have gone on to medical school. We can change that in Georgia, but it begins with the K through 12 education and exposure and bringing students from those counties to the big city of Macon, Augusta, Atlanta, etc., to see what a health system is, to see or to experience what happens in a research laboratory. And that exposure can begin with their science fair. That exposure can begin through Zoom. Imagine if each of our schools, and we had a day in the state of Georgia for 9th graders, that we did a virtual health science fair. And 3 months before that, we had identified that those students could select a mentor at one of our institutions. We could do all of that through Zoom and expose those students to a world that they may not see in their county. That is what inspires students to want to go to medical school, to go to nursing school, to think about being a biomedical scientist or a public health leader, because you expose them earlier, we plant that seed. Those are the type of collaborations that I'm looking for us to do to step out of our comfort zone to be able to be a resource for those individuals, because we should not have any county in this state that is underserved or underrepresented in their ability to receive optimal level of care. Carlos, collaborations and partnerships that are missing.
No, I think you touched, you hit the nail on the head. I think Gene and you and David have said it all. I mean, I think, we're a state that has more counties than any other state except for Texas. And it is at the level of the county that public health is happening. So I think one of the things that we need to do is we need to think, we're siloed in healthcare is in one side, public health is in the other. If COVID taught us something, is that public health and healthcare have to be working a lot closer together. So as we come out of the pandemic, I don't want us to go back to each one goes to their own seat, right? We need to continue those collaborations. We need to continue those partnerships, working with our public health agencies. And, we did it in COVID. We did it in vaccines. Well, can we do it in diabetic screening? Can we do it in hypertension? Can we do it in health affairs? Can we do it in nutrition? I mean, there's so many things in which getting our students to work with the health departments in addressing the needs at that level. We don't need somebody to come in with a stroke. We need somebody's blood pressure, diagnosed and controlled before they come in with a stroke.
Exactly.
And that's the so we need to really think about, we don't need academic health centers to start doing public health. We need to partner with the public health infrastructure, which is severely underfunded and under-resourced, and how do we help them? How do we collaborate with them to do the kind of interventions that we need at the local level? And again, going back to at the patient. And then absolutely what Dr. Montgomery Rice said, and we need to work with the educational system, because the reality is, if we're going to have people go into STEM, if we're going to have people interested in going into health professions, we have to start at that level. We have to start early on in their life. I mean, I think about, when did I start thinking about going to medical school? I didn't have doctor parents, I didn't have, relatives that were in medicine, but it was really an experience early on in junior high that convinced me that that's what I wanted to do, that I wanted to be in the health profession. So we have an opportunity to really be there, and having our students serve as mentors to really guide, the next generation of health professions. So there's a lot of things we can do partnering with what normally has not been usual partners.
So give me the opportunity to thank all of our panelists for being a part of this. Thank you so much. Academic medicine future is important. Healthcare providers are not just limited to MDs. Everybody plays a role, and we ask you to continue to play your role. We ask you to help us to get out of our silos, to think out of the box, to bring us ideas about how we can collaborate and partner. And remember, it does begin in utero. The experience of your life begins in utero, and how we care for women, pregnant women, makes a big difference. And then how we extend that care through this K through 12 experience of young people is really what's going to set the table and create the opportunity for us to achieve optimal health for all of us. Thank you so much for joining us.